Hi, good afternoon, everyone. Thank you for joining this Getinge sponsored symposium. A big thank you to Dr. Chris Krioboulos and Dr. Jason Bartos for moderating and leading this session. We're trying something unique. We're trying to keep this a very collaborative discussion with all of you. We have a live polling tool. The info is up on the screen. So at a few places in the next 45 minutes, we'll have questions where we'll encourage your participation. And now, Dr. Bartos and Dr. Krioboulos will say a little bit more about themselves and kick things off.
Hi, I'm Jason Bartos. I'm Associate Professor of Cardiovascular Medicine at the University of Minnesota, Associate Director of our Center for Resuscitation Medicine, involved heavily in ECPR. And I'm looking forward to talking to you about all things ECMO, in particular, though, ECPR and the effects of the pandemic on our program and many programs.
And as a fine contrast to that, I'm Chris Creel. I'm a cardiac intensivist over at Emory. We've seen a lot of leaps and bounds in our program, as have I in my junior aspect of my career. My predominance in involvement has been as part of our VV ECMO cannulation team, and then on the intensivist side, and now as we're transitioning more into non-surgical VA ECMO as a cannulating group, as an intensivist group. It's excited to talk to you guys, share stories, learn a little bit more as we're moving into this phase of transition.
So as Alan said, this is going to be very different than any of the other talks here. It's supposed to be very informal and casual, and the goal is to hear from you as well. Certainly if you have questions about what we're saying, about our experiences, you're more than welcome to ask those, and people are roving around with mics. You can also just yell at this point. We'll repeat your question for the group, and we can talk if it takes a while for the mic to get to you. But also, if you just want to share your experience, because no two centers are alike, and all of you will have had experiences as well during this time. And so please feel free just to share your experience. It doesn't have to be a question. But certainly, I'm, again, looking forward to talking about the impacts of this on everything. And we'll start, actually, if I may, by asking Chris a question. So if we can, we can just start by talking, because I think when we talk about the effects of the pandemic and where we're going in the future, it's useful to know where we started. At least for me, it's very much a comparison to what was happening in, say, December and January 2019, before at least we were really aware that there was a freight train coming, and we were standing square in the tracks. And so if you could say a little bit about what your program was like in that time frame in 2019, what your numbers were like, your process, your patients, and how you were managing ECMO at that point.
So at that point, we were pretty excited that we'd been growing exponentially as a program numerically. So we were doing about 50 cannulations a year on average in 17 and 18. And then later into 18, moving into 19, we'd started reaching the 130s, 150s. You know, pneumonia was still one of our most feared complications. We were dealing with sequelae of that, working on a rehabilitation process, our wake and walking ECMO, which we're huge proponents of, and we were pretty proud of the progress that we'd made with respect to that. We'd started incorporating, we had a motley crew of about 3 intensivists, and then the rest was cardiac and thoracic surgery, so our intensivist group was really excited to have an opportunity to help and manage these patients at time of initiation of therapy, to get the exposure to cannulating, and then to start expanding that into our management afterwards and decannulation, et cetera.
And what was your mix, if as best you can remember, the VA, VV, ECPR sort of mix of patients at your institution?
Yeah, so we were at about 50-50. We had a VA predominance at, like, again, that 18 range, but had started moving more into ARDS and some chronic respiratory failure. We've got a relatively large, like, regional and catchment area. And worked pretty nicely with, like, Piedmont and some of our other community centers. So we had started skewing towards a VV predominance, I think just because of staffing and capacity and ability to do that. And I think the other thing too is, like, interval development of Impella. When we start looking at, like, some of the other devices that we have as far as, like, durable, implantable, non-implantable devices, what options do we have with isolated LV failure? That's really started to kind of expand as we saw over those past few years. And I think we saw a bit of that trend and change in overall with VA.
Very nice. So sort of a 50-50 mix, growing program year over year. And from the region or from your sort of patients coming into the ED in your ICU? Were you transporting a lot of folks in?
Yeah, so we were transporting a lot of folks in. We started doing remote cannulations, and so we were still doing about 45% of remote cannulation initiation and then transfer in, and then another 25% of that would have been patients that were already cannulated at another center that were sent over for like transplant evaluation, et cetera.
So if we could just move then up to the point where you became aware that the train was coming at you in the tracks. The pandemic was sort of brewing. What was your first impression? How did your program adjust to knowing that there was a pandemic coming that was ARDS predominant? What was the approach and the feeling at that point?
Trepidation and fear. I think we left Society of Critical Care Medicine, had their annual conference, I believe, in like that end of January, beginning of February, and at that point in time, we transitioned from the phase of rumors of pandemic to beginning phases of this is reality. As far as from a preparation standpoint, we, as a critical care center with the different specialties, we work really well together, and so we talked about contingent plans as far as pulling in volunteers, whether that's attending faculty, fellows within the specialties to staff our units, and to provide some of like the bare bones first line provider in the setting of some of our providers being ill or that possibility in the future. And then we started employing some of like our surgical residents, fellows, and trainees, depending on their area of interest and specialty. We started employing them and having plans to move them either to the ED to help in the obstetrics areas, and at least starting those conversations so we had a contingent plan. Some places we actually acted that out, and other times we had less of that, but it was pretty interesting as someone who was newer in faculty to be working aside as like a primary provider with some of my attending faculty that had been on faculty for 20 years. How's that note going, guys?
It's perfect. So just the poll results are up there for the modes of ECLS that people were performing before the pandemic. Sounds pretty similar to what you were talking about in terms of half and half. Now, this isn't exactly the number of patients, but it is the number of facilities that had each modality. So 50% with VV, 50% with VA, and 36% with ECPR. The 5% that did not have an ECLS program before COVID. It would be great to hear from you, not to put you on the spot, but this is a pandemic is quite a time to develop an ECLS program, unless you haven't yet and you're about to, which is great. But boy, would we love to hear what your experience was like trying to put this together during a pandemic, if you're out there. Okay, so could you talk a little bit about the challenges? Every program has challenges. We all do all the time. What challenges you saw for your program before the pandemic, and how, whether you had challenges for your program, and how you saw the pandemic affecting those, again, as you're sort of staring it down. For us, for instance, we knew we had bed capacity issues, ICU bed capacity issues before the pandemic. And so for us staring at the pandemic coming, it looked like we were going to be in for it. That we were going to be overflowing with patients when we were already almost at capacity. But did you have some of those challenges that you were already dealing with, and what did the pandemic look like for that?
So we already were at Grady. We started looking at overflow between units. So like the trauma surgical ICU became a relative hodgepodge of COVID, non-COVID. We expanded, already had issues from a capacity standpoint. From a staffing standpoint, earlier on, we started kind of catching this wave and premonition of how many people would be departing for various locations, would be deployed for various reasons to other states to either, provide first line support. But whatever that meant for us, it meant that there was a transition in our team. And so even just having some of the standards of continuity of care and like practice base that we had set up, there was a whole new phase of like education, familiarity with what's going on, with how we manage these patients that, we prefer to not have a RAS of negative 12. We actually want to be able to, mobilize when these patients clear. But everything from that to capacity, and then kind of some financial implications with, post-cardiotomy shock, depending on the duration of time that was there, were already things that we were getting looked at from an administrative standpoint. All right, well, how long are these patients staying? What's the throughput? How is this impeding? We still had some of those residual patients. We had some of our VA recovery post-MIs, and then we sprinkled on what we now know is like exceptionally long durations of EV ECMO support in a time where ORs were frozen. So it was quite a hodgepodge.
Yeah, I think those challenges are pretty common for all of us. I think we all experience a lot of that. even now. I would like at this point, I guess, to shift a little bit and compare this to the ECPR world in 2019 for us, because it was a blissful time. I think for us, pre-pandemic, we were at that point, we had started our program in 2015. Our ECPR program, our formal program, I guess, we had gotten to the point about 50 cases per year of ECPR based at the University of Minnesota, sort of all the patients coming to us. We had developed the mobile program, going out and cannulating people in emergency departments in outlying areas of the Twin Cities, so we could cover a little bit beyond the metro area. And we had started the ARREST trial. So the ARREST trial, our first patient was enrolled in August of 2019, not knowing that there was, again, the freight train coming. And so, we were very excited. It was a very exciting time. We thought we were on a roll and things were going really well. And we were, again, having the bed capacity issues, but that was about it. The first 4 months of our mobile program, we had 60 patients. So we took our yearly total of 50 patients or so, and we did it in 4 months, the first 4 months of that program. And that was also very exciting. So we were going to be on track for 180 patients or so a year. So all that felt very good. And then the rumors of a respiratory illness that was coming around the corner started to hit. And the question became, can ECPR continue in the setting of a pandemic, especially a respiratory pandemic that has overlap in this equipment needs, staffing needs, et cetera. So the ECMO machines, the ECMO staff, the nursing staff, ICU beds, et cetera. And so, again, as I think of 2019, it's sort of a happy time. We had the challenges, but we were really feeling quite good at that point. So, for us, reaching out and transporting people, because we were doing primarily ECPR, it was about sending our team out almost universally to cannulate and bring them back, because we were doing ECPR. And there were some unique challenges that came with COVID for that. But for your transport program, I noticed that you published a paper, a beautiful paper, actually, describing your transport program. And something like 60 some odd patients in the first year or so of COVID. And you had something like a 60% survival rate for these patients. And that's in the first year of COVID, which, again, as I remember back, I was, as a bystander for VV ECMO, just I guess one clarifying point, at our institution, a different team manages our VV ECMO patients for the most part. So to some extent, while we were there to be supportive, we were watching a little bit of what was happening with the VV ECMO patients. And I would be driving into work or whatever, listening on the radio and hearing people talk about, from very well-established centers, from different parts of the country, saying, yeah, we're not really offering ECMO to our COVID patients because we know it's not going to work. Because the early data that was published said that ECMO was a disaster, that basically the patients were a disaster, and nothing could save them, was effectively the message of some of that early data. And, as I didn't have the authority or the reason to say that these people were incorrect. That's not what I did. But at the same time, it made me worry, thinking that we were going to move on from a modality that could potentially be helpful for these people. So for you, being so lodged in VV ECMO already, so invested and so part of the process, and now talking about this huge catchment area that you already have, and you're bringing in all these patients, how do you convince, I guess, your hospital administration, your team, all the people involved, that it's worth doing, that it's worth going against some of these centers and some of these people that are talking about it not working? And how do you get the news out that actually you have 60% survival and people are doing well with this therapy despite taking a long time to recover? They're still doing well, despite the news that's out there.
So I guess if I had an answer on how to convince hospital administration of anything, we'd all be doing a lot more things that we like or dream about. I think in this case, some of it I can attribute to quite personally, I think some of our administrators having a personal involvement with either loved ones that had been sick with ECMO and seeing the work that we'd done in the past, I think there was enough trepidation, but also some suspicion as to whether this wouldn't be efficacious as far as we knew, because we also at the same time had relative parallel data saying that although these patients are a mess, Atlanta is not exactly the non-messiest of cities, and a lot of us practice at Grady, and so this is kind of our normal. We also were at a program where, again, this was really small. ECMO was far away. We had not been walking with cannulas, so I think a lot of that was just collaboration from administration and being able to play along with, you guys have a track record of providing this service. If you guys think it's appropriate as an intensivist group, as a thoracic surgery group, let's try it in a small volume. And so that's where we generally started. And then quickly having the outcomes that we did and being able to get that available to them. I think a lot of eyes and ears were on us, which was nerve-wracking, but then being able to bring those stories, we then were able to quickly bring in buy-in through our system. And then through Atlanta, we've got some great ECMO coordinators at our programs that are meeting and talking regularly anyways, and had been talking better about how to serve the city, how to collaborate. When we are either at capacity before pandemic, a lot of that word started continuing to spread, and so it spread fairly naturally. I wish we could take credit for how that occurred, but sometimes the best things occur that way.
Well, good news travels fast sometimes. I think, just to refer everybody to your paper again, I think it's in Perfusion, the journal Perfusion. One of the coolest things about that paper from a person who does a lot of transport is that you have an actual visual figure of a form that you send to the places where you're going to cannulate. And this form, for those of you who are thinking about transport or are doing transport but can refine things like we all can, this form includes a long list of supplies that you expect them or want them to have on hand when you arrive. I thought it was fantastic. We should have this for every ICU procedure we do as well. But there's this list of all the labs that you want drawn, the supplies you want provided, the staff that should be there, including having family available so you can consent the family, which is fantastic. And then at the bottom, something I thought was just, again, really neat, was that you have a list of the staff you're bringing with you and their names so that the people that are receiving you know who they are, those people, and they can figure out the roles and the names of people. It just, as a program that does a lot of transporting, we can learn something, certainly, from everybody, but this was something that I took out of that paper. It's quite fantastic.
I'm glad to hear that.
Any thoughts about how you developed your program and how any organizational tips that you have for people who are trying to do that, bring those 60 patients in a year or more?
No, I have some of the similar questions for you, which we'll transition over to that shortly, I'm sure, as you all do as well. No, so I think some of that was this was created out of necessity and trying to find some organization and structure amidst the chaos. And a lot of our supplies were just like extra OR towels. Do you have an ultrasound machine? Do you not? Do we need to borrow the fellow's butterfly that they somehow got on the list for 7 years ago? Not a proponent for any portable ultrasound brand, just as a disclaimer, but trying to figure out what resources we needed to bring. And in these transports that were greater than 4 hours away, one distance, crossing state lines, that took a lot more preparation as well. Having the team members and availability, like our clinical perfusionist group who's sitting up here and the rest of the team members, I think added a bit of that personal aspect. And also with the coordinator role, they've kind of provided, now we have 2 in our program, but she provided a lot of that continuity. So families had a reference point since visitation was limited, and that's how we found a way to kind of breach that and provide a little bit of human connection with our family members. We're working on expanding, and that's actually one of the questions that I wanted to talk to you as an audience about and try to get a little more information and open up was how do we, and those of you that are either accepting transfer patients, doing remote cannulations, how do we kind of bridge that gap in communication before we're even meeting these patients? So we've talked about having like a welcome letter in pseudo layman's terms. So for the medical team, our supply list came with a bit of a welcome letter for the ICU. Here's what to expect. This is how long this generally takes. There's going to be this members of the team. We'll need, whether it's like IV heparin, a bedside nurse, someone that can help us with hemodynamics. Do you have an ultrasound? Do you not? We've talked about creating one for family members as part of like preceding some of that consent process, a little more information about ECMO. Here's our team, here's what we do. Thanks for letting us take care of your family member. We've talked about pamphlets. for family members and other loved ones. So I'm curious if any of you guys out there have any resources that you've created or used or that you've found have helped kind of facilitate and bridge that with your programs.
Anybody want to talk about the resources that you've created? A family guide?
That's awesome.
Yeah, that's fantastic. So a family guide that you laminated and everything, huh? So it's mess resistant. That's wonderful. So that's the sort of materials that families, as much as they may hear about ECMO, especially in the COVID times, in the media, having something that clarifies the myths about ECMO as well seems like a great idea. Yeah. So, yeah, just thinking about the transfers. You mentioned, as far as I saw in the papers, like the longest was 8 hours away. That's a long transfer. So, and that, like you said, one direction. So that's the transfer with the patient. Your team has to go out there 8 hours the first way to go and do the actual procedure and get everything ready. Did you find any issues with those longer transfers? How did you, I guess one question is how did you even know to go there? Were those referral centers you already had in place beforehand? Did you create new referral centers, or did new people call you out of necessity or out of just knowledge that you're doing these amazing things? And then also, were there any specific issues with those longer transfers?
So it was a mix as far as our referral base. I mean, there's definitely, once you have partners that you're used to working with and you have a good understanding and good communication about what your patient's going to look like and what their candidacy looks like on paper, on the phone, and when you actually get to the patient, you don't have a lot of those surprise medical discoveries on arrival. That definitely helped, especially with these longer transports. As far as issues, we had almost no complications that were documented, minor or major, in route and transport. I think some of that was as a factor of us wanting to stay and make sure that we had, a subsequent gas cannula position, however we wanted to confirm that. And sometimes in ultrasound, sometimes we just took a flat plate and moved it up and did a little bit of a glorified fluoro perspective with some of our more challenging cannulations. We talked a little bit about some of that with the obese population, but making sure that we were at a stable point. The other thing that I think was unique is we had a pretty large fellow pool that was very interested, and they participated in every transport in addition to a clinical perfusionist, and that was the base team regardless of whether we were initiating support or transferring someone that was already in support. And then again, preparation, whether that's, having extra products crossed ahead, making sure that we are hemostatic and not going to have issues, and a little bit of foresight. But I think all of those factors definitely contributed. We had one ambulance break down at some point on the side of the highway at around 2 a.m. in the rain on a patient that we transported prone. So that was my favorite story. I was on that transport. We did a bit of a switch of the ambulance in the rain with the prone, morbidly obese patient. That had been a challenge to cannulate. And so I called our program director at the time, and I was like, this may be the one that does it for me. I always joke I'm going to have an MI at work or a stroke at work at age 40. And I was like, this may be the one, Mark.
Yeah, I'm sure that night made stories for many people. So the other thing that sort of drove home, when I was just reading through again this paper, drove home the complexities of that situation for me, and maybe triggered some PTSD from the time, was that one of your adverse outcomes was transmission of COVID to a team member, which there aren't too many circumstances in the world of ECMO where one of your adverse outcomes in a study would be catching the disease the patient has. But that's a unique aspect of what we've all lived through for the last few years. So when you're thinking about 8 hours in the back of an ambulance in a confined space, maybe that time on the side of the road helps air things out a little bit. But were there things in particular that your team was concerned about, or things early on in particular when none of us knew what all the best practices were? Maybe we don't now, but even then much less. Were there things that you did as a precaution, or things that actions that you took to prevent it?
Yeah, I think, earlier on, preservation of PPE was definitely one of them, and then depending on how dependent they were, how functional their lungs were, and the contribution that it was to gas exchange, in some cases, like we would clamp ET tubes, make sure that we were either, making sure we were maintaining control, clamping with disconnections or any kind of disconnections, using different filters as that provided, but that was about all we could. I mean, I think as far as like things that we had concerns as a team, I don't know, you guys, if you guys want, not to put you on the spot, but some of the things that I feared the most were contracting and bringing that home to my family, and then how do we mitigate that? A lot of us, showered immediately when we got to work. I ran into a bunch of people around the locker room. We'd switch out scrubs. We'd do the best we can, but short of what we knew at the time, I don't know that we did anything novel or different.
Yeah, it was a crazy time for sure. And certainly if anybody wants to talk about anything they did, which even in retrospect wasn't all that helpful, it's sometimes fun just to discuss how we all dealt with this. So the other thing I wanted to bring up was something which I found impressive. So it's easy for us to publish the results of heroic efforts, or what we consider like the great cases, right, where you have the great save. But you actually, within, I think it was something like May or June of that first year of the pandemic, you published a case series of 5 patients with basically acute right heart failure in the setting of COVID. And, New England Journal, kind of a big deal. Finding time to publish it all in that time when we were all sort of drowning in the chaos of the situation is impressive. And to publish a paper that primarily showed that these patients did poorly. I mean, really, it was a paper that showed this is a warning sign for the rest of us to say this is a bad thing that can happen to COVID patients. They're hypercoagulable, and they're getting these PEs, and they're dying of right heart failure. And I thought it was really impressive, again, that you published bad outcomes, which is not something that everybody's willing to do, even when it's not of your responsibility, but still just publishing bad outcomes is hard, and that you found the time to do it in those first few months of the pandemic. Can you comment a little bit on how that played out, how you felt about trying to put together this data as you're undoubtedly getting slammed with patients at that point?
It's kind of hard to call a book report data. I joked about that a lot. I was like, this was just a book report message out to the world. Hey, we're seeing this. This is really concerning. I think one of the things I was talking about with our Toronto colleagues, like just actually a bit ago before we came on stage, was, a lot of the humility and lessons that we've learned in taking care of these patients. So if anything, what the pandemic has done, I think for a lot of us, and having a former career as a nurse and then transitioning into the world of medicine, is this kind of this humbling experience where we have no idea what's going on, what's happening. We're getting data as we go. We're, throwing out case reports, smoke signals from random places in the country. We're trying to talk and do the best we can. And I think that was the really beautiful thing to see in the medical community, is seeing us all unite over this. And, we're seeing real data in these beautiful publications that are telling us that this therapy worked. But that's because we were able to kind of put down whatever metaphorical, geographical boundaries we had, get together as a community, whether that's a community of intensivists or a community of ECMO specialists as different team members, and be able to get this information together. We did what we had to do. We lost sleep together. We, showered at work, slept at work, took naps in call rooms. We did whatever we needed to do, not just to take care of our patients, but to make sure that we could all better take care of our patients globally. And
No, that's fantastic. And you mentioned it, something that makes you very unique among physicians is that you have this nursing background. And you do cross communities. You have experience in both communities. So can you talk about how that impacted things for you at all? Is that something you feel did change your approach or your ability to link the different communities of medicine in this time of chaos?
I mean, 100%. I say, like, nursing has always had my heart, and I definitely think I was a better nurse than I was a physician. I think the things that I'm proud of most as a physician, I think I learned in nursing and continue to learn from our nursing colleagues. But that also spans to, like, our respiratory therapist, our physical therapist, and honestly, our patients. I think it plays into how we talk about communicating with our patients, how we talk about consenting our patients. So we can talk a little bit. I mean, we've talked some about criteria and how we're expanding and kind of pushing past these boundaries of what was considered normal with respect to, criteria, candidacy for ECMO cannulation, areas that we became more courageous in expanding, whether that was in a couple of the cases that we've seen recently, and, the peripartum gravid patient. in patients with larger BMIs, and in our even just like our cannulation strategies, like how did we deal with these patients that had increased oxygen consumption, that had a superimposed bacterial infection, that had been doing well. We woke them up, we were able to get them extubated, and then all of a sudden I couldn't support them the way I needed to metabolically. You're waking them, and you think about like cerebral oxygen consumption. We were seeing a lot of these changes and challenges, but I think we became courageous and continue to be courageous, and I think all of that came from that.
That's wonderful. So the data that Ellen had up there about the effect of COVID on your cases, so I think this makes a lot of sense for a lot of our experiences. For the majority of people there, it obviously increased the cases. For some of you, three people started a program. Again, would love to hear from you and how that went. Congratulations for sure. Starting a program during the pandemic. And for some of you, it decreased cases. So there again, I think I'm one of, again, as an institution, our cases were increased, but as a person, my field of ECMO was decreased during the pandemic. And I can definitely see where VA ECMO, cardiac ECMO, and ECPR may have been triaged a bit during this time. There are two things, I guess I would say, in comparison to what we've been talking about so far in terms of the ECPR world during that time. So the first was there's a lot of uncertainty about resuscitation in these people. I don't know if you experienced that. Some states experienced it more than others, where EMS organizations had a lot of concerns about resuscitating and PPE, reasonably so. And hospitals with capacity issues in some states basically banned for short periods of time bringing patients with ongoing resuscitation to their hospital. And that was a big hit for ECPR. At least the way we did it at the hospital, they had to come with ongoing CPR. Now, our hospital did not ban that, but still when EMS agencies read across the nation that this is what people are doing, it slows down their willingness and desire to think about bringing us patients as well. So it certainly decreased our numbers. In addition, we were closed a fair amount of the time. Starting around June or so, from June until pretty much March this year, we refused around 160 ECPR cases during that time because of bed capacity issues and availability. And so that obviously is a drastic decrease in numbers, but it's also a drastic decrease in our ability to communicate and maintain those relationships with EMS, and they stopped even calling at a certain point because they knew our answer was going to be no the majority of the time. So that certainly, again, I can empathize with the decrease in ECLS cases. My question now, as we're transitioning away from the depths of COVID, where we may never be free of it, but we're transitioning from the depths, is your experience with the increased numbers, this large catchment area, where does it go now? So are you keeping all those practices and plans? Are some of these patients going to other centers, or are you really charging ahead and increasing your numbers even further with now being able to bring back maybe some of these other groups and categories of patients?
Yeah, so the categories thing I think has been most interesting, like becoming a little more involved with like leadership and planning and med ed in our program, because we've definitely seen a huge uptake in our VA, and not just like our post-cardiotomy VAs, but again in ECPR within like our healthcare system within our hospital, and then these more like atypical shocks. I think if anything, COVID provided, and it was one of the questions I had for you, is like interested a little bit in this perspective. So we've talked a lot about like media influence, acceptability, some of the work outside that our colleagues have done in Toronto and through the critical care collaboration. So now we've kind of gone through this phase where everyone was like, oh, Eolia and Caesar child, and like, well, we have to see, we're so married to the ventilator, it's comfortable, it's what we've done for so many years. We know that within these parameters we can safely support and take care of our patients. Well, now we're kind of transitioning over into this different phase of it's becoming a more accepted option, and so we're seeing some more atypical consults. And that's something that I wanted to kind of ask the audience as we're kind of talking about the effects of the pandemic and our approach overall to ECLS. Like, I've noticed some more atypical consults, so whether that's in the PACU with some negative pressure pulmonary edema, where, you know, they come out of the OR, we're waking them up, they don't respond to sex, we can't break them, they constrict, and then we're cannulating for them. Next thing we know, either in the PACU or throwing them back in the OR that hadn't been turned over since the last day were there. We're seeing more status asthmaticus and, you know, like CO2 retention in like really extreme cases. And so we've been able to preserve that partnership. I think we're seeing more of a diversity within our patients that are meeting candidacy for VV, and then seeing this huge uptake in VA. And so I think this is, I don't know, I could sound a little cheesy right now, but I'm really curious and excited about this awakening into the world of VA and the world of ECPR. And you guys had set up so much for this. You described this like relatively pseudo-dormant, although while the rest of us were publishing book reports, you were publishing the arrest trial with your group. So kind and humble, but I would like to know where you guys are headed next, and one of the things that you have kind of seen in this transition phase, some of the challenges you've experienced, how have you responded to those, and then what lessons can we learn from you?
Yeah, to some extent, we're children that have been staring through the windows of a candy store for a couple of years, and now the doors are opening. And so we're hungry. What we're planning and what we're doing is just getting back to what we were doing in 2019 and expanding that. So we, as I described it, had 2 rings of service back in 2019. We had the university-based program where patients would come to us from roughly a half-hour drive time away, so they could get to us in the cath lab. We'd cannulate them, and that was, again, about 50, 60 cases a year at that point. And then we had the mobile program where we were driving out to these outlying emergency departments that were preset, pre-trained, and stocked with supplies to be able to cannulate people with ongoing CPR, standard ECPR patients that we had been bringing to the university, but they were meeting us halfway, so we could get to them faster and we could extend our reach quite considerably. And that's how we were getting to our 60 patients in 4 months at that point. And now we've rolled out the 3rd option. So I should take one step back. The arrest trial, the last patient enrolled, we were lucky in many ways that the effect size was so big, and they stopped us early because the last patient enrolled in, I think it was May of 2020. So rolling that through the rest of the pandemic would have been a challenge. But yes, we were able to get that published during that time. It was a nice little bit of downtime, I guess, to get that done. But now, taking that forward, so we've now rolled out our mobile truck so we can go and cannulate in people's front yards and bring them into the truck. It extends our reach considerably and really opens up entirely new areas of the state. Our goal, as stated 2 days ago and also for a couple of years here, is that really the goal is to bring the same quality healthcare, the same ECPR program we had at the university to the entire state of Minnesota. And we're not going to stop until we've accomplished that, and the truck is the next step in that. So the numbers are going to be even higher now that we're able to do that. And as you may know, the arrest trial and our ECPR program since 2015 has been focused on people with shockable rhythms, VTVF, and that, again, was the criteria for the arrest trial as well. But the hope is that when we can get to people sooner with the truck and with other means, then we can also open up to other rhythms. So you may know that if you look at the overall cardiac arrest population, about 1/3 of those people have shockable rhythms and 2/3 don't. So our numbers would triple effectively if we can open up to non-shockable rhythms. It won't be exactly that proportion because we'll probably be a little more restrictive, but the numbers will skyrocket. And any of you doing ECPR, you've probably experienced that the PEA patients take up a big portion of that population if you're open to it. If you're not, like we weren't, then obviously you're doing shockable patients. But those non-shockable folks, there's at least a subset of them that can be saved, I'm convinced. I just don't know how to identify them. And so you end up doing, I think, a lot more ECPR for fewer survivors on average, though we're working on selection. So the future of ECPR for us is very much taking the ECMO to the person so we can expand, cover the entire state, get to the point where easily we're doing 200 to 300 a year, if not more, especially with PEA added. that our survival continues to increase because we're getting to them quicker, and we know that for every 10 minutes of delay, we lose about 25% of our survivors. So, every minute, 2.5%, we're pushing every minute. And then work on the selection criteria, and certainly we like to let everybody know and try to publish everything that we discover along the way so that other people can learn from it too and give us feedback. So hopefully we'll be coming out and telling you what we find along the way here.
I'm super excited. So one of the things that I think, or two of the things that were mentioned like in arrest was like availability of the team, and we talked about response time. How were you able to do what you did from like a staffing perspective, from a call, from a team standpoint?
So there are a couple of key things to the mobile program in particular. The first is that our mobile program started and is still a consortium of multiple healthcare facilities and systems. So we weren't bound to one system and the availability of those personnel. We could pull personnel from multiple hospitals, multiple systems, and we could use the resources and the facilities and the emergency departments of multiple healthcare systems. It also allowed us to talk to EMS providers and EMS medical directors as an unbiased resource. So in our community, most of our EMS providers are associated with healthcare facilities, not 100%, but most. And so for them, if we were bound to one healthcare system, the others would be looking at us with some concern or with some hesitancy. For us, they were all open. And part of that also was absolutely years of relationships that were built before ECPR was ever a thing. So bringing all that together in multiple healthcare systems was critical. The second was training and just bringing the whole team together. So we connected with a flight service, a flight EMS service that had flight medics and nurses who were already trained to transport patients with ECMO that were stably cannulated. We trained them how to cannulate so they could anticipate the steps and the process for the procedure, and they could be our first assist for the cannulation. And then we brought in physicians again from these different healthcare systems, most of them ED physicians and critical care physicians, to learn and to try to move toward cannulation. Also a couple additional interventional cardiologists, so that was helpful. So building this team was how, from pulling a few stragglers from different places, was how we built the team. Especially, we built the team largely pre-COVID, but we maintained it during COVID as best we could because we weren't stealing an entire staff from one hospital. We were just pulling a few people here or there. So I think now that we're post-COVID, that team being in place is a huge benefit. Now we're able to mobilize them again consistently without these intermittent closures, as I was talking about, and really bring them to bear on the whole community. The system of care component has a team that is dedicated to the mobile ECMO team and mobile ECMO service. So that team is able to serve the truck as well as these other outlying emergency departments. Having a university-based program is actually very convenient, especially one based in the cath lab, because we can use the cath lab team. So at this point in the Twin Cities, we have two teams, the cath lab-based university team and the mobile team. They're always ready to do ECPR. And we can be a little flexible. If one team is busy, we can still use the other team as well. So as everybody else is thinking about ECPR, everybody's excited, hopefully, about ECPR. Beyond the 35% or so of people that were doing it during the pandemic, certainly the system of care matters a lot, and having that connection with EMS all the way through the connections to the critical care and the post-arrest care, you can't really skimp on any of those steps. Everything is absolutely critical.
So for some of the programs that are either building or hoping to expand that, there have been some challenges post-pandemic with respect to not just burnout, but overall turnover in medical professions, whether that's pre-hospital setting. We've seen this with nurses. We've seen this with regional hospital closures and other hospitals being inundated with kind of absorbing those, like some of the things we've experienced in our medical center. Advice or words or thoughts on how to address that? Like, has that been an active issue for you guys thus far as you're starting to really engage and ramp up? Have you found ways to kind of mitigate that, or has that background helped?
It's a huge issue. I mean, the issue is sort of compounded by the pandemic and all the stress and burnout that everybody had sort of already brewing, I think. And then you add a patient population where a good result is when 60% of your patients die. That's what we deal with in ECPL, right? That's a great result. If only 40%, or if 40% live, you're doing great. And so it's hard. It's hard for nurses that are talking to families and trying to work through it with patients at the bedside. It's hard for physicians and trainees. It's hard for pharmacists and everybody. I think the steps that we used to take to mitigate this have also been eliminated. So we used to have survivor dinners or survivor visits. We'd bring the survivors back through the hospital. At least at our hospital, we still can't have random visitors. And so we can't have a survivor stroll through unless they're coming to see a friend or they're coming for an appointment or something like that. And so that's really limited some of our previous stress mitigation strategies. One of my partners is here, I think, Andrea Elliott, who's been working with, she's one of our cardiology critical care attendings, and she's been working in clinic to create sort of little storyboards, so to speak, for the survivors so that we can bring the stories at least into the hospital for the nurses to hear and to realize that what the person they last saw intubated and leaving the ICU or leaving the unit to go to a neighboring unit where they had beds because we were filling all of the beds in our ICU with ECMO patients. That patient that was still looking very, very sick is now walking, talking with their family, something they haven't seen for a long time. So those sorts of strategies to bring that back into the hospital have been helpful. We've also started working with our palliative care service and other resources to try to just bring some debriefing and sort of talk therapy effectively to our teams, just to get all those stories out and try to help people deal with the sticky things that are there, because we've all got them, and it's true of our trainees, and they oftentimes don't feel like they can say those things to their teams, I think. So trying to bring some of that out for ICU teams as well. But I think team longevity and stress debriefing or stress mitigation are definitely issues we're still going to be dealing with for a while. And it's a really critical point that's probably been underappreciated for quite some time.
Have you all experienced that or found ways to help mitigate some of that within your ICU teams, your care teams, your ECMO teams? We, again, started out with a pretty motley small crew. So we have like a WhatsApp or like a GChat equivalent. And so whenever we have patients that we're seeing in clinics, so like one of my favorite stories is our patient made it to Orange Theory, and the man runs better than I can walk. I'll do a flight of stairs and he's less winded on a treadmill, but sent us a video of himself like at Orange Theory doing his first treadmill type workout. And that kind of just blew up through the chat. And that's one way that we've found unofficially. We've been talking about similar things like storyboards from outpatient clinic, both with our ECMO patients and our transplants. And for those that are shared, we have a board like in our workroom where we'll post either, survivor photos, letters, etc. But have you guys found ways in your center that you found that this is effective, or ways that you can reach out and kind of hear from patients, provide a little bit of that longitudinal perspective? A survivorship?
Can you guys hear me okay? So, in the very beginning, we did like quarterly meetings and in-person meetings, and once COVID happened, of course, patients weren't able to come back to see us. So we started doing virtual meetings. And what we really realized was how much PTSD and mental and emotional instability and health that our survivors have needed. So right now we're working to create a survivorship program. So we all include better comprehensive care once they leave the hospital, so we can have them see, spiritual help, financial assistance programs like that. So that we need these for the patients we're, performing. It's going to be a meeting with them monthly and once a month, and we're really hoping here soon we'll come back. We're trying to partner with some of our psychology services at the university to have that support every time that we come in.
That's fantastic.
Yeah, that's wonderful. That's a very all-encompassing program. That's really well developed, so well done. So we are running a little short on time, so we want to get your words out there, your phrases. So it doesn't look like there's any single phrase that hopped out to people in terms of how your approach to ECLS was affected by the pandemic, but certainly a lot of different impacts. And I think many of us can probably empathize with the fact that many of us have experienced all of those. Need more ECMO beds, could not echo that more. Growth, news, just a million different ways that this has impacted us and will impact us going forward undoubtedly as we continue to grow programs, grow the indications, refine the indications and the patients that benefit. So thank you all for your attention and thank you all for participating. This is a very interesting discussion for me and I learned a lot and certainly hope that you did as well. If you want to talk with us after, I'm certainly available. We can talk more as well. And thank you for sharing your experiences in particular. Really do appreciate that. All right, thank you.
Thank you. Thank you, Dr. Kriopoulos and Dr. Bartos. And thanks everyone for attending.